So now let's come to the Andromeda trial. So how do a combination of CRT, pulse pressure, diastolic arterial pressure, and basic echo together help classify hypovolemia, vasoplasia, and cardiac dysfunction? So what made you bring all these three into one category and help us in classifying hypovolemia versus vasoplasia versus cardiac dysfunction?
Yeah, so the first, let's say, branching of the tree on our protocol is done by pulse pressure. And pulse pressure is a nice surrogate of stroke volume. It's cheap, it's simple, and it's bedside. And pulse pressure is determined by aortic compliance and stroke volume. So with a low pulse pressure, you're probably having a low stroke volume, and then we test fluid responsiveness. So then we can assess if the patient is actually preload dependent or not, and give fluids accordingly. So if we find a patient with a low pulse pressure and fluid responder, she's probably requiring fluids and hypovolemic. On the other hand, if a patient has a normal pulse pressure but a low diastolic blood pressure, diastolic blood pressure will be determined mainly according to vascular tone and heart rate. And there's a nice paper by Professor Ospina that he mixes these two and called diastolic shock index. And these patients are broadly vasoplegic. So in this sense, what we're aiming here in this, let's say, other subset is to increase vascular tone through vasoactive drugs and avoid giving fluids if they are not required. And if any of these two big interventions fail to identify or to restore capillary refill time, we come to the beginning of tier 2. That's a basic cardiac echo to rule out right or left ventricular dysfunction. So with these three interventions, we can check these big, let's say, patterns or phenotypes that we were talking about.
So it's amazing. You covered all the things. You looked whether the patient is hypovolemic, or maybe the vasoplasia is playing a role, or maybe the cardiac dysfunction, and accordingly you precisely decide about the therapy of the patient. So very well planned. But how reliably can these macro phenotypes be identified without advanced monitoring? Is there any role?
What we have is we published last year or this year preliminary data, and we found that pulse pressure at least has a very nice specificity over 90 to identify a low PTI with a cardiac echo. So we cross-checked pulse pressure and stroke volume through echo, and we found that it has a big specificity. And also the diastolic blood pressure signal, there's a study by, I told you, Gustavo Spina Tascon, that assessed this relevance, and also another one by Professor Tebul that he used an acronym called VNERI to assess vascular tone and responsiveness to norepinephrine. So at this sense, I think that even though they're not perfect tools for a first approach, and we must remember that usually we do not have access to echo at the beginning of resuscitation, and we do not have access to, let's say, cardiac output monitoring at the beginning or during early resuscitation. So these simple bedside tools can help us sort out, at least in this protocol, 63% of the situations and normalize capillary refill time without using an echo was required only 1 out of 3 patients. So this is the nice thing of the study.
So when you talk of the diastolic arterial pressure, it's quite a bit of under-recognized thing, I believe, because classically we have been taught to look after the MAP. All guidelines, be it the sepsis guideline by SICM or the sepsis group, they all talk about the MAP. But here very well we have spoken about the diastolic arterial pressure. So is it something which is under-recognized resuscitation target in vasoplasia? And what is the interpretation of the success rate of DAP augmentation of more than 50 millimeter of mercury?
Yeah, that's also, I think, DAP is the forgotten brother of the mean arterial pressure, or the forgotten sister of the mean arterial pressure. And actually, it's a signal that we're looking at vasoplegia, and probably increasing vascular tone could enhance not only arterial flow, but also coronary perfusion. And in this sense, in the study, 120 patients went to the DAP test or to the DAP augmentation, and only 20% in normalized capillary refill time. So it was a little bit, we found it a little bit insufficient compared to the other tests. But when you see the raw numbers, when you see the absolute decrease, capillary refill time decreased a lot from 7 to 4. The problem was that it did not reach the threshold of 3 that we categorize normal to abnormal. So right now we're running some post hoc analysis to see the true value of these tests, and I hope we can have them soon finished. But we're still under construction.
Yeah, amazing. Would be interesting to have a look at that data as well.